Good morning, everybody. It's 8 a.m., so welcome to Pediatric Grand Rounds. And this is the Roger Johnson Ophthalmology Lecture. And I'm Suzanne Mazer. I'm the Director of Continuing Medical Education here at Seattle Children's. And now I will turn the virtual microphone, over to Dr. Cabrera, who will be introducing our speaker. Thanks so much.
Good morning. For those of you who don't know me, my name is Mimi Cabrera. I'm the new Chief of Ophthalmology at Seattle Children's. I want to start by thanking Christina Tarsi-Hornock for her 7 years of service as Division Chief. We're really fortunate to have Christina on with us, and I speak for our division, ophthalmology department, and Seattle Children's wider medical community in saying that we're so grateful for her dedication and hard work in growing and developing the division over the years. I'm also pleased to announce that Avery Weiss, previous chief and longtime Seattle Children's pediatric ophthalmologist, researcher, and leader, who many of you know and love, is officially returning to our division as Professor Emeritus. We're really fortunate to have access to his expertise in research, clinical advice, and education. So without further ado, I'm honored to introduce our Roger Johnson speaker today, Doug Frederick. Doug is a professor of ophthalmology, deputy chair of education, and chief of pediatric ophthalmology at Mount Sinai School of Medicine. He obtained his medical degree at Baylor College of Medicine, ophthalmology residency at UCSF, and his pediatric ophthalmology fellowship at Children's Hospital, Boston. Medical education has always been an important aspect of his professional life, and he served as residency program director at UCSF, Stanford, and now Mount Sinai. He is a recipient of the Honor Award for the American Academy of Ophthalmology and the Association for Pediatric Ophthalmology and Strabismus. In 2019, he received the ACGME Parker Palmer Courage to Teach Award, recognizing him as one of the 9 best program directors out of 11,000 in the country. I was not surprised to see that he received this award. I was a medical student and a resident at UCSF at the time that he was program director there. And I can honestly say that I have never seen a single faculty member who inspired more residents and medical students to follow in his footsteps, including me. Doug embodies a kind of dedication, authenticity, and compassion in teaching and clinical care that we all aspire to. We're so fortunate to have the opportunity to share our virtual space with him for the Roger Johnson Lecture today. Please join me in welcoming Doug Frederick.
Mimi, thank you so much for that very kind and generous introduction. It seems like yesterday that you were a med student resident, and when I left right in the middle of your residency, that was one of the saddest things about leaving UCSF. But here we are, flash forward a few years later, and having the opportunity to speak to you and your colleagues and to the pediatric community of the Northwest. I feel very grateful. And first, for my disclosures, I have nothing to disclose. I am a unpaid scientific advisor for a device development company, and I am not going to speak about anything else. But I do want to speak about Roger Johnson, the person who we are honoring today. So Dr. Johnson was a giant in the pediatric ophthalmology field of the Northwest. And the attributes that made him such a beloved individual really start from where he's from. He is from the Midwest. He has Midwest sensibilities. He received his undergraduate training at the other UW, University of Wisconsin. But it seems like his first experience in the Northwest was when he served as an intern at the Children's Hospital in Portland. He returned to Minnesota to receive his residency at Mayo. But then, because of his experience, probably as an intern, he realized that the place to be, the place that would make him the most happy, the place where he could serve his patients the best, was in the Northwest. And he returned to Seattle, where his tenure as chief of ophthalmology at Children's Hospital was legendary. I don't know if you've had any other chiefs of services whose tenure extended 40 years. But that's a testament, because it's not easy to be chief anywhere. It's a testament to his equipoise, his ability to serve as mentor, his ability to serve and endure during trying times. He really has become the dean of pediatric ophthalmology of the Pacific Northwest, but he's done much more than that for his patients and his specialty. He and his wife, Angie, endowed the Roger Johnson Lectureship, of which I'm delivering today, 35 years ago. And when you look at the list of past recipients and speakers, it's really the who's who of pediatric ophthalmology. I feel like a true imposter being here today. But that's okay. I'll fake it for at least an hour. In 2001, they endowed the Roger Johnson Award and Lectureship for Macular Degeneration Research. And here again, as Dr. Van Gelder will attest, this is the who's who of macular degeneration researchers in the country and world, and really the most important thought leaders and researchers in macular degeneration have been awarded this prize and given this lecture. And then finally, in endowing the professorship in pediatric ophthalmology, of which Dr. Weiss was the first recipient of the chair, he really cemented his legacy. And legacy is really what we're talking about. I advise you to, if you have the opportunity to go to the UW website and search him, you'll learn more about his past. And I appreciate Dan Carr telling me about his influence on him as a young pediatric ophthalmologist. And when you talk to Dan and other people who knew Dr. Johnson, it's really the legacy that will live not in publications. Publications become dusty journals that are in some storage facility now, or they become digitized bits of information or code that will be sometimes accessed, but oftentimes not. But the legacy that will endure will be that in the memory of the patients he served, the colleagues who he's allowed to mature and grow and develop their full potential because of his mentorship. And it's truly an honor to speak at this lecture today in his name and honor. So speaking of legacy, we'll get started today by talking about our roots and where we're from. So I am from the Bay Area, specifically from San Jose, Silicon Valley. I know Dr. Van Gelder, Mimi, many of you have either lived or worked in the Bay Area, which again, now we know is Silicon Valley. If you look at this slide, this is all the companies and startups, just actually a fraction who have started in Silicon Valley and changed the world because of that. But Santa Clara Valley was not always called Silicon Valley. It was actually, the name of the Santa Clara Valley was the Valley of the Heart's Delight. And as opposed to Silicon Valley, which again is an inorganic name, the Valley of the Heart's Delight was really an organic place, aromatic, if you will, because people would travel from San Francisco on an electrified streetcar to come to San Jose and sit under the apricot and cherry and prune orchards in the springtime and enjoy the environment. And so even back then, we had ways to find the truth. People wanted to find their way. Do you know the way to San Jose? They wanted to find the way to San Jose to experience something that was true and real. And back then, even in the, again, 40s and 50s, there were maps that showed us the way, to experience the Valley of the Heart's Delight. Now, we have new maps. We have new ways of finding our way. And this is, 3 different Google Maps, Apple Maps, Waze. There are many different ways we can find the truth, find what we're looking for. So part of this, a lot of this talk today is really about truth. So if you look at how is truth defined, well, truth is the daughter of time. In other words, is truth can change. It can be relevant and not exactly rigid or solid. It can be plastic, as we're seeing. Francis Bacon took that quote from Agellius and said, truth is the daughter of time, not of authority. You might see where I'm going here. So Peter Latham stated, the truth in all its kinds is most difficult to win, and truth in medicine is the most difficult of all. Now, who was Peter Latham? Peter Latham was the personal physician to Queen Victoria. He was really the William Osler of London, of Britain, of his time in the Victorian era. And he had to, take care of a high maintenance individual. Here's another quote from Peter Latham. It says, it takes as much time and trouble to pull down a falsehood as to build up a truth. And so what I'm going to talk about today is about truth. Truth that you need to be armed with when you encounter patients who ask you about alternative therapies. So we're talking about therapies that we didn't learn about and you didn't learn about in medical school. We didn't learn about as ophthalmologists in our residency, but your patients will come thinking they know what the truth is. So if you look at the amount of money that's spent on alternative therapies, you can see it's quite a bit. It's $14.7 billion is spent on complementary practitioner visits and therapies. I use that number because it's interesting. If you look at the amount that Medicare expends each year for the training of physicians for every single one of you residents and interns out there, it spends about $14.5 billion a year. So we train all of our future physicians with the same amount of money that's spent every year on alternative therapies. So keep that in mind as we go forward. So how do we find the truth? How do your patients find the truth these days? Well, we know which way they find the truth and how truth is now defined. This is an old picture back in the good old days, right? When Google and Facebook was going to save the world, bring us together and tell us the truth. And we know in recent years, this is not a new, this is an old article from 2015, 5 years ago. Should Google always tell the truth? That's a discussion we can continue after grand rounds, a discussion that we have amongst ourselves every day. So what is the truth? Let's start about truth in numbers. So if you go to Google and I search myself, I find that I get 6.13 million hits. I'm feeling pretty good about myself. I'm feeling, all right, that's not so bad for me. But what if I refine that a little bit more? So if I put MD after that, well, it goes down from 6 million to 4 million. That's okay. I'm still feeling good about myself. What if I put Douglas Frederick, New York? Yikes. Okay, people don't know that I'm here, so I'm falling off the map, only down to 1.8 million. But what if they actually refine the search and say, no, I don't mean Douglas Frederick, I mean Douglas Frederick. It drops down to 400,000 hits. And why is that? Well, because Google defines me not by me, but by the other Douglas Frederick, well, the other Frederick Douglass. So again, I don't mind having sharing a name with one of the most important figures in our nation's history. But this is to illustrate that we have to beware of the internet. I don't need to tell you this because, again, particularly as pediatricians who come, who take care of a lot of patients, a lot of your parents are Microsoft and tech people who think they know the truth. Just like when I was in the Bay Area, almost all my patients came in knowing the truth because they had researched the truth before they came to me to get a true answer. But how big of a problem is this, and why are we spending time? I mean, I could be talking about pediatric cataracts, but what's the incidence of pediatric cataracts? It's 0.03%. So yes, you're going to see, as pediatricians, you will see maybe 1 or 2 newborns with pediatric cataracts. You must know about it. I'm glad you do. Refractive errors, super common, right? This is the time of year where people have their vision screened in your office. You have lots of questions about what instrument I should use to screen my vision. I could be talking about that. Could be talking about strabismus, which again happens in 2-3% of patients. Patients who again will be seen for a long time. You'll be seen for a long time. You'll be asked to pre-op them for their surgery. But what do we share in common the most is children with learning disabilities and problems with reading, that they will come to you about advice. Is what am I going to do with my child when I'm getting so much different information, so much different advice, solicited and unsolicited, from family members, from teachers, from people that they meet online. So what is vision therapy? Well, it depends on how you want to define it. So vision therapy is a doctor-supervised, non-surgical and customized program of visual activities designed to correct certain vision problems and or improve visual skills. Here, if you search, go ahead and search, if you get bored of my talk, you'll find these sites all over the place. So look at the definition of how people define eye strain. So ask yourself, have you had any of the symptoms? Does computer work give you a headache or blurred vision? Here's a scary one. Does your child avoid homework? They can have a vision problem. They can have eye strain. Does your child have a learning problem? Do you get car sick? What percentage of your patients get car sick? Well, if they have any of those things, by golly, you've come to the right place. So what is vision therapy? And we're going to define it a little bit more specifically. So there's vision therapy that might be called orthoptic therapy, behavioral vision therapy, amblyopia therapy, or myopia prevention vision therapy. And we're going to touch on all of these because you need to be armed with the information to give your patients the right advice as to how to proceed. First, let's talk about orthoptic vision therapy. So orthoptics is a discipline where these are individuals who receive 2 years of education in taking care of children with vision and motility problems, as well as adults with motility problems. It's a rigorous course of training. The individuals are certified. They take both a written exam and an oral exam, and they work with ophthalmologists in taking care of children with these conditions. So that's what an orthoptist is. Orthoptics is the branch of ophthalmology and optometry that looks at eye motility and sensory abnormalities of the eyes being used together in a binocular function. So there are certain conditions that may be amenable to orthoptic vision therapy: convergence insufficiency, convergence excess, accommodative dysfunction, and strabismus. So let's first talk about motor problems and reading difficulty, right? Because when you have a patient who's a slow reader, oftentimes the teacher said, you need to get your eyes checked to make sure that there's no visual problem. And so one of the things that we look for is convergence insufficiency. So convergence insufficiency is the inability of any of us to be able to focus on an object at near. And you can test that yourself. When you get old, it might get blurry, but you still should be able to focus with one finger as it comes closer to your nose. And there's a way to measure that more accurately and more quantitatively. But patients with convergence insufficiency can get asthenopia. That's a good Scrabble word. It's a long word. But asthenopia means that feeling of a spring tightening between your two eyes that causes eye fatigue and strain. Get headache and blurred vision. And again, you can measure convergence abilities through the use of prisms and very specific techniques that both ophthalmologists, orthoptists, and optometrists should be able to do. And there's a defined definition of what is convergence insufficiency. So part of it is a problem with the near point, or inability to focus at near, or the decreased ability to overcome induced strabismus when a prism is placed in front of you. And you've probably all heard about simple exercises your patients might have been prescribed, such as pencil push-ups. Again, looking at a pencil as you bring it close to you to keep the eraser focused and not double, going back and forth to build up the ability to converge. There are other exercises as well. We'll show you an example of one in a moment here that are exercises that can be done at home, or they can be done in the office, or they can be done on your in your own computer. So those of you who are online and not looking at a big screen, you can do this test yourself. You see two pictures of a kitty cat. If you cross your eyes a bit and try and focus right in the middle of those two cats, all of a sudden, what you should be able to do if you have good convergence is you'll be able to see a single cat in the middle that's got whiskers, ears, and a tail, as opposed to two individuals. So how many of you in the audience can do that? Raise your hand. Mimi, thank goodness. Okay. Great. So that's what convergence is. That's one of the ways we measure it. And that's one of the ways we give patients exercises to make it better. So let's talk about what you can do for convergence exercises. Here's a study. What is the evidence that vision therapy is needed for such therapy? Well, they randomized patients to treatment in the office, treatment at home, or no treatment whatsoever in patients who had convergence insufficiency. And it showed that between home and office, there's not much difference, but between doing nothing and doing exercises, whether that's at home or office, there was a significant difference. So exercises do help. Well, here's the first paper I want to talk about. So this was a randomized clinical trial of treatment for convergence insufficiency in children. Now, you can see that there is this is done pretty much by optometrists. And again, disclosure, some of my best friends are optometrists. I love the way optometry helps me take care of children. And so this is not an indictment of optometry. I'm just telling you what the fact is. So this was a study that was published in the Archives of Ophthalmology. And this was the first article actually in the new year, the new calendar year. This came out in January. And what did the study look at? And what did the study become? It has become a Trojan horse. So in this study, which it looked at 47 children. They randomized the patients to 12 weeks of office-based therapy versus home-based therapy versus placebo. And the results, which you could look up yourself, was that vision therapy orthoptic was more effective than pencil push-ups or placebo in reducing the symptoms of convergence insufficiency. So this is how they defined success. They didn't define success as increased ability to read for longer periods of time. They didn't define success as better comprehension on standardized tests of reading or learning or memory, but reduced symptoms. And so their endpoint was this convergence insufficiency symptom survey, which I'll blow up a little bit easier. So they asked these patients, these children, the questions: do you have any of these symptoms? Do your eyes feel uncomfortable when you're doing mirror work? How many of you have not experienced some of these items on the list? Getting sleepy when reading or doing close work. Okay, all of you residents who are interns who are, studying for your boards, studying for your internal examinations, trying to do your reading every night. How many of you get a little tired when you read that? Yes. How many of you forget what you read? Any of us over a certain age? We are finding, yes, that we're having a hard time remembering what we read, or we have to reread it over and over again. So again, this was the reference standard. And this is the way they're defining success. And what they found is that, golly, the people who spent more time in the office seem to have a better score than those who didn't. So what is the truth about this? And this was in an accompanying editorial, which was in that same article, that same journal, from Bert Kushner, again, a sensible Midwestern at the other UW at University of Wisconsin, Madison, who said the problem was is that home therapy they recommended was completely suboptimal. It was insufficient to get the same benefit that could be accrued in the office. And the other thing that the authors of the paper didn't mention is that the average cost of that vision therapy is over $1,000. So again, I mentioned a Trojan horse. So a Trojan horse is because once something is in our literature, as we all know too well, given recent events with COVID-19, once it's in the literature, it can become truth. So if you go back to one of those behavioral optometry websites, you will see them say, but a study in Archives of Ophthalmology found that home-based regimen of pencil push-ups was ineffective for convergence insufficiency among children with this condition. So it's truth. It's cited as a reason to validate the therapy that they're going to recommend at this site for behavioral vision therapy. What's the second type of orthoptic condition that may be amenable or may not be amenable? That's accommodative inability. Well, I'm sitting here struggling to read my laptop without my Costco reading glasses. Accommodation is something you young people in the audience have. Us older people, we lose it. But we lose it at different rates. And accommodation is related to convergence, the turning inward of the eyes. And you can measure that. You can measure accommodative amplitudes by asking people to look through lenses and see how efficiently or quickly they can focus through either diverging or converging lenses. And so this is something that can be quantified and measured. And a lot of vision therapy addresses this accommodative insufficiency, but there are no randomized controlled trials looking at this to see whether or not it's efficacious in the treatment of children with learning disabilities, certainly, or even whether it gives symptomatic relief. What about orthoptic treatment for strabismus? Absolutely. Orthoptic treatment for some forms of strabismus is useful, as we talked about. So if you have patients who have inability to converge at near, well, exercises do work and can lead to decreased amount of symptoms when done properly. And a set of home exercises can work very well. On the other hand, if you have a child who has an esotropia, an in-turning of the eyes, then an in-turning of the eyes, then you don't want to do orthoptic therapy in the sense of trying to make them aware of the double vision. This was done in Europe in the 80s, where instead of treating people with glasses or surgery for esotropia, they did vision therapy. And what happened is, as a child, it made the eyes straighter, but as soon as they became 40 years old, they could no longer control the alignment, and then they got intractable to double vision that couldn't be made to go away other than wearing a patch over the eye. So you have to be careful as how you deliver orthoptic therapy and which people you recommend it for. So what are the facts? So orthoptic vision therapy can relieve symptoms of convergence insufficiency or excess. But I want to talk mostly about behavioral vision therapy, because this is what you will be dealing with. This is what your patients will be asking about. So the premise of behavioral vision therapy is that visual perceptual motor skills can influence cognitive adaptive skills. And you'll look at and you'll see in these long reports, and you'll get these long reports from behavioral vision therapists when patients come to you and said, look, will you please pay for this? And this is the report that's delivered to me. And you'll hear about things like ocular pursuit, eye teaming, eye tracking, laterality training, eye training, perceptive training, hand-eye coordination. So when I first became interested in this topic, I was still in the Bay Area. I went to UC Berkeley School of Optometry library. UC Berkeley School of Optometry is fantastic optometry school, first or second in the nation, depending on whether you live on the East Coast or West Coast. And I went to the librarian, and I said, can you show me where I can find the definition of eye teaming or eye tracking or laterality training? It doesn't exist. So there's no defined definition of all these things that are invoked in these reports that our patients get from behavioral vision process. And you'll often see, and again, the behavioral optometric point of view is the process of deriving meaning from what is seen. Well, that's a pretty philosophic or pretty heady description of what vision is. And it's something that, again, can be defined like the truth. What is the truth? So the assumption is that abnormal eye function is associated with difficulty in both reading and non-reading visual information processing tasks. Processing tasks is something we'll have to come back to. So what are the requirements? What do your patients, your children you take care of need in order to read properly? Well, they need a lot of things. They need the right neurologic wiring between the eyeballs and the brain. The information needs to get from the retina to the visual processing cortex and has to move within the cortex, the associating cortex appropriately. You need muscles that work, that are innervated properly and work smoothly and efficiently. And of course, you need the proper optical focus. You need to be able to get that image focused on the retina appropriately in order to have good vision. Now, we know, again, all of you, pediatric residents, interns, and medical students who might be watching, this picture always shows up on your standardized board exams, right? If you have a lesion in the pathways, what kind of visual symptoms are you going to get? And we know as pediatricians, as optometrists and ophthalmologists, that we have to provide accommodations to people who have some forms of hemianopia, right? So you can have a right hemianopia, which means you can't see everything to the right on both visual fields, or a left hemianopia where you can't see everything to your left in both eyes. And so, you would think that since we read left to right, a right hemianopia is worse. Well, it can't be worse because oftentimes if you've had a stroke or a developmental anomaly that interferes with the visual pathways on the left side of the brain, that's where speech and language and the associative cortex lives. So yeah, you could have a reading problem. But if you just have pure vision problems, we actually read 7 letters at a time. So even with a complete hemianopia, usually with our macular fovea, we're able to read a word fairly efficiently. But if you have a left hemianopia and you're moving along, and like the typewriter for young
Hey,
people.
Doug, can I interrupt you for a moment? Can everyone make sure you're on mute? I think there's like a ticking sound from someone's computer.
Okay.
Thanks.
Thanks, Mimi. If you have a left hemianopia and you get to the end of the line and you have to find your way back, your eyes are drifting into nothingness and you can't find your way back. So that's the most difficult hemianopia or visual disability due to problems with the optic pathways. So how do you fix that? Well, you have the patient, you have the child use a straight edge ruler, and they use that as they go down the line to find their way back. So simple interventions. Now, we're talking about vision therapy. One kind of vision therapy that's been proposed, and it's still out there, is vision therapy for hemianopia, or called visual restitution training, so VRT. This was a computer-based therapy that you, as a provider, it's almost like a franchise. You belong to it and you administer in the office. So it's 5,000 euros. It's a European-based company, and this is from, again, their website. And what it says is this is the way the world looks to your patients who've had strokes before vision therapy, and look what happens. Look what you can see afterwards, after you do this vision therapy. And I think actually Mimi was a resident when Dr. Horton saw some of these patients who had been through this neurologic restorative vision therapy and actually analyzed them a little better. But look at the who's who of people who are on their scientific advisory panel. This was a heavy hitter list. You had people from, Nancy Newman, who's a goddess of neuro-ophthalmology at Emory. You have people at Mass Eye and Ear. Not only that, you have Carla Schatz, right? The leading neuroscientist both at Harvard and now at Stanford, or Torsten Wiesel, the Nobel laureate on plasticity, who is on their advisory panel saying, this is great therapy. Well, is this the truth, or is this not the truth, or is it somewhere in between? So if you look at these patients, this was a study done in the UK, where they actually looked at the way people with visual hemianopias use their eyes. And what they found is that if you do simple testing of visual fields, but you don't carefully look at what their eyes are doing, the people with hemianopias very quickly learn an adaptation where they make small little microsaccades. In other words, movements of the eyes that are so difficult to see that unless you are looking at the fovea with a camera while you're doing the visual field test, you can't see that they're actually looking into the hemianopic field. So the therapy that they recommended had nothing to do with them improving their visual function. This was simply an adaptation which the patients did all on their own. Again, it took an article to get these other scientific advisors to say, well, maybe I need to take my name off the list. And, there have been Cochrane-based reviews looking at evidence-based approach to looking at interventions for visual deficits in people with stroke. And there's been zero evidence, so far that any of the therapies as soon as up to 2019 were efficacious in the restoration of visual field. Again, adaptation or increased function due to adaptation that might work, but not restoring vision where it once was lost but now is found. What about vision therapy for amblyopia? So you all know what amblyopia is. You all have patients who come in with an eye patch or say that my doctor is putting a patch on the eye to make the vision better. Amblyopia, it can be seen in patients who have congenital cataracts. It's seen in patients who have strabismus. Most commonly, it's seen in patients who have one eye that's very far-sighted and the other eye that's nearsighted. We all take care of these patients. And patching or penalization, use of atropine, is the kind of the gold standard for treatment of this. But there have been, again, in our tech world, in our Bay Area world, if patch is good, but it's old. If you can do it on the computer, it must be better. And so this was called neurovision. So instead of using simple patching, this was more active approach to visual rehabilitation, doing a set of exercises where the individuals would look at slightly blurred images or contrast sensitivity tasks and spend time doing the tasks. But what's the problem? First off, it was proprietary information. So the evidence of whether or not it was efficacious really was not shared. It was never peer reviewed. And it said it was efficacious from the age of 9 to adult. Wow, I thought that amblyopia was pretty hard to fix when you're 50 years old. Now, we all know, all the ophthalmologists who are listening know, yes, there are cases where somebody with bad amblyopia in one eye then becomes blind in their other eye at the age of 40, and now the vision can get better. An extreme form of patching therapy. So there are case reports of that, but most people with amblyopia don't show much improvement after a certain age. But this site claimed they did. So the question is, that we're going to spend the rest of our time talking about, and how you can, arm yourself to help your patients is, what do you do when people come and says, well, we really don't need to see the ophthalmologist or the pediatrician. We have providers who are recommending therapy that we're convinced will work just as well. So again, these behavioral vision therapies will what they do is it's a pretty standardized approach. You do an assessment, you do a course of therapy, uh, and um, and then you recommend maintenance exercises. Now, the exercises, we'll see some videos of what these entail. Almost always the children get spectacles. Oftentimes the glasses will have the slightest amount of correction, the slightest amount of prism. And there are other add-ons, other additions that you can be offered, and often parents feel obligated to get. And the average amount of behavioral vision therapy is $3,000 to $5,000. Here's the kicker: most kids who have a true reading or learning disability oftentimes will still be getting traditional therapy through the school district or through a private tutor, in addition to the behavioral vision therapy. If you have a family that manages to come up with $3,000 to $5,000, they often can come up with a little bit more to do additional therapies in addition to what the school district is providing. So here's just from, these are from behavioral vision therapy websites. You can see this upper left, that was called a Brock's string to measure convergence. Here you can see these tasks. It's interesting. They often do these with patches on, which I think is interesting because if they're trying to restore binocularity, I don't quite know why they're doing this one eye at a time. But anyhow, you can go online and you can see the different types of tests. Now, what do these tests all entail? All of these tests are timed tests. So in other words, when they do the assessment, they will tell the child, okay, I want you to read the letters F, O, D, C, T, and they'll see how long it takes to get through that. They will do the same test, say, okay, now read the letters, but I want you to bounce a ball at the same time as you're reading the letters. So proprioceptive tasks as well as reading tasks. They'll want you to go to a chalkboard and I'm going to touch your back, and I want you to tell me on this diagram, where am I touching your back? Again, perceptive abilities. They want you to write binocular circles. So with your hands, do circles clockwise in both hands, counterclockwise with both hands, or opposite with both hands. In time, see how long it takes to get through that certain test. There's bean counting. Again, I used to think that's referred to the accountants of the behavioral optometrist, but this really means taking a jar of beans and taking the beans from one jar and putting them into another, seeing how long it takes, or using a metronome to become more efficient. I'm not making this stuff up. This is stuff that I found from UC Berkeley School of Optometry library about vision therapy. Use the arrows. Tell me, Janie, which way is the arrow going? Up, down? Which way is it pointing now? Up, right, down, middle, down, right. And then finally, oftentimes these are tilt board tests. So you're doing these same visual tasks as you're standing on a tilt board that is moving to, again, try and integrate vision. Here's the thing that scared me a lot when I first noticed it. Did you know that there's a correlation with bad handwriting and learning disability? That's the case. Probably half the people in the audience need to see their vision therapist right away because your handwriting is not so good. So what is the evidence? What is the evidence about vision therapy and learning disability? Not very much.
So what is the evidence about vision therapy? So here's again, favorite from Dilbert. What can I do to avoid getting computer viruses? Give your power cord a spinal adjustment once a week to prevent disease. I was skeptical until he said there's anecdotal evidence that it works. And so this is the problem. And I think that how many of you in the audience have ever heard of the Rosenthal effect? This is important work that was done by a pediatric psychologist in the early 60s. And so this is a study, it was actually, again, done in the Bay Area, where they took essentially first and kindergarten students. And at the beginning of the year, they tested the students for their intellectual ability, IQ tests. And what they found is they randomized them. So the kids in the two classes had equal abilities, but they told some of the teachers that you have an exceptional group of children this year. That's all they did. They said, you have a special gifted class. And then they tested again at the end of the year and found out that by the end of the year, the students had stratified to groups. When the teacher was under the belief that the children had great ability, the children did better, performed better, and showed an improvement in their abilities. So this is the essentially, call it if you want, the Pygmalion effect, the teacher's expectation leading to improved performance, that any sort of therapy has an effect. And so you can believe that, a steaming pile of something is going to make you feel better. And if you're the people who support that idea also convinced, then often you'll feel better. So call it placebo effect. But again, in education, it's called the Rosenthal effect. So here's the problem. With learning disability and visual difficulties, there are no randomized controlled trials. If you look at the previous studies, there's no standardization, no norms, no correlation to scholastic achievement. And if you look at evidence-based reviews, there is no clear scientific evidence in the mainstream literature supporting the use of eye exercises. The Academy of Pediatrics and the Academy of Ophthalmology and our subspecialty society, APOS, has all endorsed a position paper which says, again, the following, and this has been revised and re-endorsed: that vision problems are rarely responsible for learning difficulties. The children with learning disabilities generally have the same ocular health as children without. And there's no evidence that academic abilities of children with learning disabilities can be improved with vision therapy. So this is a statement that we keep this in our office and we hand it out when we get that report from the parents asking for them to authorize payment for vision therapy. So again, if it looks at in this report more specifically, it says treatments that have inadequate scientific proof of efficacy should be discouraged. Ineffective, controversial methods of treatment such as vision therapy may give parents and teachers a false sense of security that a child's learning difficulties are being addressed, may waste family and or school resources and delay proper remediation. So I'm going to talk about Trojan horse again, and I don't hope to offend some people, but that's okay because I'm getting old and I can do that. So I trained at Children's Boston, and if you go on their website today, you will find in the ophthalmology section, vision therapy service, frequently asked questions. And here's the problem, where data gets obfuscated in the capitulation and legitimation. So if you look, it says, many ophthalmologists advise their patients that there's no benefit to vision therapy. And while that is true, there are a few randomized controlled trials that show benefit. And there may be some cases where vision therapy can be helpful. That's all you need. That's all you need. So if it's good enough for Boston, then it's good enough for me, right? And I have to say, at other institutions I've worked at, I've heard the same thing. If you can't beat them, let's join them. At least they'll come and they'll get things done in a more rigorous manner. But what it does is the halo effect. Again, it legitimizes people who are providing the same therapy, even if it's not the same therapy at their institutions. So what is the role of the physician? So the role of the physician is, our job is to rule out problems with their eyes, strabismus, problems with a nerve, the retina, treat refractive errors, look at muscle imbalances. And then what do we tell the parents? We tell them the same thing you do, that they have to get tested through the school district, that they have to be pushy, right? Especially this year. I feel so badly for all of you pediatricians in the office, right, who, your children are not going to get their vision screened at school. They're not going to get their hearing tested. They're not going to get all the other services that school nurses used to do. So a lot of these things are going to be missed. And if you have a child who's got a learning concern, you're going to have to be even more aggressive. Tell them to write a letter of concern to the principal or the superintendent. Do it in second grade. And again, as you all know, speech therapy, in some states it starts at the age of 3, not just in kindergarten. Educating your parents that what speech therapy involves, the difference between a 504 plan and an IEP, and educating your trainees. I mean, again, for you, those of you residents and interns who have never heard of a 504 and IEP, you need to learn about that. And go to appropriate websites, whether it's the Orange Foundation, the Schwab website. I have this article from Sally Shaywitz. This is a classic Scientific American article that is written at a level that most of your patients should be able to understand, that explains dyslexia better than anything else I've seen published. So get that and pass it out to your parents if they are concerned about dyslexia. And refer them to appropriate websites where the content is moderated and validated. I want to spend some last little bit of time, again, something a little bit light and fluffy, and it will kind of presage what we're going to talk about in the next hour, is vision therapy for myopia, because this is a hot topic, right? Your patients will come in as pediatricians, and they'll be asking about this. So again, be prepared. So if you look again on the web and you see the International Myopia Prevention Association, you'll see this picture of this man. This man is the head of an organization, head of the National Eye Institute, who's responsible for ruining the vision of your child. Look at this. He says that you'd be surprised that this taxpayer-funded organization is leading to the deterioration and blindness because of what we're doing to our children. Well, kind of harsh. But this is based on people who strongly believe in the Bates method. Now, you'll hear about this. It's still alive and kicking. Thousands of these books are sold each year on Amazon. The Bates method for better eyesight without glasses. So who was William Bates? So he was a ophthalmologist who lived in New York City, 3 miles from where I'm sitting right now, who believed, and again, this is so reminiscent of what's going on in medicine today. So my clinical observations have of themselves been sufficient to demonstrate the truth. So if I see it, it's got to be true. What I see is what must be true. That they've also been sufficient to show how errors of refraction are reproduced at will and how they can be eliminated to temporarily in a few minutes and permanently by continued treatment. And he believed that lack of sleep, unfamiliar objects, strong light, noise, that certain foods, these are the good foods, black olives, potatoes, plums, and look at all the things on the bad list. These are the bad foods, acid-forming foods, all the good things in life, caviar, chocolate, wine, so he was convinced the homeopathy, that diet can affect your vision. And there's a series of exercises. These are still advocated by practitioners of myopia prevention today. And I'll show you some of these pictures. So this is called, palming your eyes, putting your palm over your eyes and imagining what the way the world should look like. Well, we all do this a lot these days. We all close our eyes and wish the world would go away or it would change. Eye gymnastics, this is my favorite one. Looks like there's some form of convergence training. Pencil push-ups, blink, blink, blink. This gentleman who runs this site, he also sells the myopter. And there's a whole kit that you could buy online. Improve your eyesight naturally through blinking, palming, sunning, Melissa exercises. It looks as a form of juggling, where you juggle a ball in front of you while you're wearing a black piece of paper in front of your eyes. Looking at the computer, going outside, looking at the sun, knowing, shifting your body in relation to reading. The long swing and the short swing, the shoulder and back releases. Look at these exercises that people believe in. So this is from this person's website. Sounds true. That's the name of his publishing company, but it ain't true. This is completely bogus. And the other thing you can learn from this talk, if nothing else, is the concept of breakage. Breakage is what late night marketing is. In other words, it's the same thing when you buy, prepay for a service. If you buy a Starbucks card and you don't use the last 35 cents, you just throw it away. Well, 35 cents times a million cards is a lot of money for Starbucks. Same thing for direct marketing. The direct marketers know that you could mail somebody a box of dirt and guarantee that dirt will help them grow a magic beanstalk. And if it doesn't, you get money back guaranteed. All you have to do is replace the dirt in the package and pay for shipping, and we'll send you your money back. What percentage of people don't do that? A vast majority of don't do that. And there are price points that people know when you can sell them a box of dirt and still get your cash. So that's what direct marketing scams are. So that's an example, again, of a form of vision therapy that your patients will still ask about. So in conclusion, so both ophthalmologists and optometrists prescribe therapies which affect vision. So we use therapy that affects the vision. The term vision therapy means different things to different people. And statements concerning the efficacy of therapy have to define the goals of therapy and must have quantifiable and relevant outcomes. The ethical ophthalmologist and optometrist prescribe simple eye exercises which can alleviate astenopic symptoms associated with accommodative and convergence dysfunction by using glasses and simple exercises. But unethical ophthalmologists and optometrists prey upon the desperation of parents to prescribe unproven, costly, and time-consuming courses of therapy, leading to personal enrichment, and moral bankruptcy. So I like this photo, the extent to which somebody will use their powers in order to make a buck the day after, they plan to lay off Clark Kent. We know that, again, most practitioners, eye care providers, whether optometrists or ophthalmologists, are ethical. But it's our job to be strong advocates. So don't be wishy-washy about this. You have evidence and you have science on your side to dispel myth and to put people in the right direction. So I appreciate the opportunity to deliver this lecture. I really wish I could be with you today. I look forward to seeing you in person. I hope that some of you can stay on for the next hour because it is related to myopia specifically, which again, your patients as pediatricians will be concerned about and talk about. I want to thank Mimi particularly because I know that she had a lot to do with asking that I be named as this lecturer. So I'm deeply grateful, Mimi, for that opportunity and honor. Look forward to hopefully seeing you in person someday soon. Thanks very much.
Thank you so much. This is Suzanne. I'm just going to ask a couple of questions to conclude this hour. And again, if you're staying on for the next hour, please feel free to do that on this same exact link. And two questions that I see. One, is it possible to share the link for the dyslexia handout in the chat? And if not, you can send it to Emily and we can make sure to get it to the person who's asking this question.
Okay. I promise to send it to Emily. It's on the AAP website as well. You
Perfect.
can find it in the resources, but I will promise to send it to Emily to send it to all of you.
Okay, great. And Leah, we'll get that to you. And then from Jared Roach, what do you think of atropine drops for the prevention of myopia?
Well, hopefully you can stay on for the next talk because we're going to talk a lot about atropine. So yes, I am a believer. And I do use it. And so, there's, especially again, you're in Seattle, you have a very large Asian population. You've got a lot of Asian kids whose parents are highly myopic. You've got a lot of children, Asian and non-Asian, spend more and more time on their device and doing increased near work. You're in Seattle where the sun doesn't always shine. So we're going to talk a lot about atropine. But yes, I think it's a safe treatment. And I don't know, Mimi, whether or not you're offering it through your clinics.
Yes, we do. We have a compound pharmacy in the area that we send all the prescriptions to, and we commonly prescribe it. One question here, do you have recommendations for the complicated neurological child with cortical visual impairment, particularly with regard to physical therapy, occupational therapy?
Yeah, so the diagnosis of cortical visual impairment is something that is often unfamiliar to often pediatric neurologists. I think that, again, Mimi, you probably attest to this, that you have many patients who have CVI who have been told they have autism based on the way child seem to be not looking at their parents' faces, the way they're avoiding, they look like they're having visual avoidance. So I think that early recognition and diagnosis of CVI is imperative. In the old days, we used to insist on getting neuroimaging. Oftentimes our children will have neuroimaging, but you can often make the diagnosis even without neuroimaging based on clinical observation as well as history. And early intervention has been definitely shown to be helpful. Again, it varies based on region. In the Bay Area, we were fortunate to have an organization called Blind Babies Foundation, a variety club, and I don't know what you have, maybe in Seattle. But these are usually special ed teachers who get an additional year or two of training on working with the visually impaired. As you know, these children who have CVI, they'll often have other definitely motor and developmental abnormalities. And so they have problems seeing, they often have problems hearing, they have other sensory problems. But early intervention with a specialist for visually impaired in the first 3 years of life is remarkably efficacious, but it's also super important in helping the parents become good advocates once the school district is responsible at the age of 3 or 5, depending on what state you're in. So, CVI, I mean, again, we could talk for an hour about CVI, but children use their vision in different ways. So learning the particular defects that the children have, because there can be motor CVI where the patients can't move their eyes appropriately, or visual CVI where there are gaps or holes in a patient's vision, and they'll learn accommodations in order to maximize their visual acuity, whether it's using eccentric fixation. Again, oftentimes kids with CVI, they won't look their parents in the eye because they see better when they look what looks like them looking to the side. Their eccentric fixation is better than their central fixation. So the long answer to the question that yes, intervention by a trained teacher for visually impaired children is super important. So I'd be curious, Mimi, what do you have available?
We usually go through the school systems. So they have, so there's definitely Washington State Services for the blind and visually impaired, for young toddler age kids, and then the school systems have their own system for doing vision therapy. But yeah, we do recommend that they get hooked into those. I have another question from Raghu Mudumbai. He says, "Great lecture. This war is being lost. Why is the AAO and other organizations not mounting a more significant awareness campaign about the science of vision therapy?"
Oh yeah, that's. So I'll throw it back. Why do you think? I mean, I have to tell you, and again, the relationship between organized ophthalmology and organized optometry is fraught with politics and turf. And so, obviously those of us in academics, we like working with academic optometrists. We enjoy the relationship. Those of us in private practice have our set of optometrists we work with very carefully. There's no way I'm going to fit you with a good pair of contact lenses better than an optometrist who does contact lenses. Knowing each other's strengths and weaknesses and working collaboratively to take care of a population with vision health is what we should be doing. Unfortunately, politics and money gets in the way. So the organized ophthalmology, I think, in our position papers through the Academy of Pediatrics is pretty clear in making the statement that, get the science. So as far as a campaign, other than educating pediatricians through the AAP NCE, trying to keep our websites as up to date as possible and as engaged and being as honest in our websites. But I have to tell you, and again, I don't know if there are any people from Boston listening, but I was really disappointed when I saw that website, because I know that they're looking at vision therapy from an academic standpoint. But again, once you link the two spatially in the same website, it validates it. So I think that, look what's gone on with hydroxychloroquine, right? People are totally confused because of obfuscation of science. So that's, again, a long answer that is partly political, but I think that you as a pediatrician should be very proud that the AAP has been a strong advocate for making your patients, their parents, educated, knowledgeable consumers of information, and using the policy statement, I think, is what you can do to push that along. And again, be definitive. Don't be wishy-washy, right? I think that's something that you can be very strong in saying the truth as it stands and as it's been proven through science.
Maybe can I just expand a little bit on what I meant by my question? You talked about Google and what truth means, and I think there's a lot of truth to what you said. But from the point of view of search algorithms and what pops up when you look for vision therapy and whatnot, the first thing that's going to pop up is not the AAO position paper or anything else. What's going to pop up is people's clinical practices and these large successes that they claim that they've had. That's kind of the war I'm referring to. That the average person is not going to have the sophistication or time to look for other to look for it in a very meaningful kind of way. They're going to look at Google and they're going to go to their first or second thing that pops up.
Yeah,
And
you're
if
absolutely
the
right.
AAO had some sort of way to match these algorithms so that, for example, that the AAO position paper was the top search hit, then that would make a difference.
Yeah, you're absolutely right. Again, because a lot of, I haven't searched it today, but probably the top 6 on Google, it'll say paid advertisement, right? But the truth is, people still will click the first thing at the top. Either they don't look to see that it's paid or unpaid. And how do you get the Academy of Pediatrics or Ophthalmology to be the first non-paid? That's something that, again, right? All of our, the UW has tried to jigger the algorithm so that if you search for a pediatrician in Seattle, it'll be a UW person and not a group health or whatever. I can't remember what you have up there, not a Kaiser, right? And so, but that's money, right? It requires money and programming. And I don't think the Academy, believe me, they have vital, this is not a fight that they're going to put much money into, because even though it's very important for us as pediatric ophthalmologists and you as a pediatrician, but in the global scheme, it's probably not a huge issue for organized ophthalmology, where they're dealing with optometry wanting to do surgery and bigger scope of practice issues. But you're right. It definitely. I wish there was a way, and I wish I was smart enough to figure out how to do that. But between the Bay Area and Seattle, you've got enough friends to figure out how to do that. I hope.
Doug, I like how you talk about being really definitive, because I do find that parents are actually looking for that reassurance. Like, they don't want us to be wishy-washy. A lot of times they feel this intense guilt when the vision therapist is telling them they need to do this for their child, and they feel like they need to pay thousands of dollars and spend countless hours doing this. And what they really want to hear from you is a definite answer, yes or no, is this necessary? And the wishy-washy thing is totally not doing them a service.
Again, for the trainees, I mean, just because you're young, it doesn't mean you can't be definitive, right? I think that, in all clinical medicine, that's not to mean that you're going to give full consent, full, due diligence, but you can say, look, I've looked at this problem and this is what the science says. Bam,
So I think maybe we'll take 5 more minutes. There are quite a few questions coming in, and I feel like we do have some extra time for your next topic if we can run over this in 30 for time, if that's okay. So another question from Ellen Pasloff. Thank you for the great talk. You are probably addressing this in the next lecture, but I'm curious about the use of night contact lenses to treat myopia when sleeping.
Definitely covering that. So I hope you can stay on. Don't do it, is my short answer. And we'll tell you why. But there are better ways to delay the progression of myopia. But yeah, don't like it. And I'll tell you, we'll explain why we're doing it. And again, it's all financial.
And then from Jason Chung, question to Dr. Frederick: dichoptic treatment as used in ATS study seems like a form of optometric vision therapy. What's your experience on that?
Yeah, so that refers to the treatment of amblyopia using glasses that present different images to the two eyes. So it is vision therapy. So in other words, it's therapy that's addressing a problem with vision. And again, and there is science, there's data that shows that this can be another way of treating amblyopia. So and this is the problem, right? And so if you are a behavioral vision therapist, and I think that's what the problem is that people do not put the word behavioral in front of vision therapy very often. And so they use data, whether it's orthoptic vision therapy or amblyopia therapies, and then stick it in the vision therapy bucket as validation. So yeah, the question was absolutely right. There's a lot of really interesting psychophysical. Psychophysical is the term we use to describe the way our brain interprets what we see. That's what psychophysics means. I mean, you and I are we both seeing the same color the exact same way? These are philosophical questions. But the main question is, yes, there are therapies that affect vision that definitely have efficacy. So separating the two and being definitive about what they're talking about is what our role is.
Thank you. And then from Vivian Mann, she says, thank you for bringing awareness to this issue. It helps us realize that we need more randomized clinical trials and outcomes that are objective in assessing vision therapy. I wanted to point out that there are some updated literature and studies on the horizon that even include fMRI testing. And then she includes on the chat box some studies. It looks like they're convergence insufficiency related studies.
Yeah, no, I'm not saying we shouldn't research it. And that's what the people in Boston are saying. They say we need to look at this in an academic, rigorous way. I'm all for research. And if there's a therapy that's better than what we have, if there's a treatment for amblyopia that's better than the eye patch, which we've been using for 200 years, I'm all for it. But just be honest about what the goals and expectations are for your patients. That's what we're being clear. There's a lot of interesting work on plasticity. Carla Schatz, who I mentioned, I mean, you can take a mouse and restore plasticity in a mouse, an adult mouse, and get them to restore vision that had never developed. You got to crack the skull and put a little chemical on top of the striated cortex, but you can do it. So that means there's lots we can learn about the way we see. So totally agree with the comments. And I think we just, again, need to be honest with what the parents need. What the parents need to get their children to be able to perform well and perform adequately in school.
Thank you. And then a final question. I've had patients who were given prism glasses by the vision therapist. I assume this is also useless?
Yes, usually prism glasses, again, this is a generalization. There are some times when people have true diplopia, like a child who's had a sixth nerve palsy or a closed head injury patient who maybe had a fourth nerve palsy where they have a deviation. But when you often will see prisms where they're both directed in the same direction. So there'll be one or two prisms either going in or going out. There's been no evidence that's efficacious. So yeah, and they're not cheap.
All right. Thank you so much, everyone. This concludes the hour for Grand Rounds. So thank you for our Grand Rounds audience for being here. And for those of you who are signing off right now, thanks again. And thank you, Dr. Frederick. And we'll see you all next week.